In this online e-lesson, I'll be talking to you about complex developmental trauma, and I'm going to start with a definition. This definition comes from a paper by Bessel van der Kolk, who's one of the experts in this area. And according to Bessel, complex developmental trauma can be defined as the experience of multiple chronic and prolonged developmentally adverse traumatic events, most often of an interpersonal nature and early life onset. Examples include physical abuse, domestic violence, sexual abuse, and so on. What I'm going to start with is talk about what we know about the impact of complex developmental trauma on children especially, but also adults, and then we'll also look at some research with animals. And we're going to be talking about what happens and then what also doesn't happen when children experience complex developmental trauma. So in order to get a feel for what happens when we experience prolonged chronic developmental trauma, I'm going to talk a little bit about the ACEs studies. And ACEs is an acronym for the Adverse Child Experience Studies, or the I'm going to be showing you some data that's taken from 4 different articles. They're listed at the bottom of this slide. This was a massive study, involved over 9,000 individuals. It was conducted by a large HMO on the West Coast. And basically, what the researchers looked at was, on the one hand, they looked at adverse childhood experiences, and on the other, they looked at various health outcomes. And the ACEs included verbal and physical abuse, domestic violence, sexual abuse, household substance abuse, household mental illness, and criminality. Health outcomes included substance abuse, depression, attempted suicide, smoking, poor health, teen pregnancy, and so on. And we'll be looking at data for most of these. In this first slide, we just looked. This first slide just shows how prevalent various adverse child experiences are. The people who filled out the survey report about 10% of them had experienced psychological abuse, a little over 10% physical abuse, a little over 20% sexual abuse, about 25% substance abuse had been in their home, almost 20% had experienced mental illness in their home, over 10% domestic violence, about 3 or 4% criminal behavior. And if you looked at how many had experienced at least one of these, over half of the individuals in the sample had experienced at least one. So adverse childhood experiences are common. Now we're going to turn to look at some of the outcomes. And when you look at this graph, what it shows you is that on the x-axis is the number of adverse childhood experiences that a person has experienced, starting, it goes from 0 to 1 to 2 to 3 and then to 4 or more. And then there are the odds, these are actually adjusted odds ratios, of having, in this case being a current smoker, given the number of ACEs. And you can see that if you have experienced 4 or more ACEs, then you're over twice as likely to be a smoker than if you hadn't experienced any. In this graph, we look at the relationship between severe obesity and the number of ACEs, and you can see that the likelihood of severe obesity increases with the number of ACEs, and then for those individuals with 4 or more ACEs, the odds of being severely obese are 1.5 times as great as they are for a person who hasn't experienced any of the ACEs. Here again, we see that looks at depression, and we can see that the likelihood of depression increases with the number of ACEs. and a person who's experienced 4 or more has the odds of them being depressed are 4.5 times as likely as they are for a person who hadn't experienced any. Here we look at attempted suicide, and this is really of all the outcomes. This one bears the strongest relationship between ACEs and the likelihood of the event. In the sample, 3.5% of the individuals report having attempted suicide, but we also can see that if a person had experienced 4 or more ACEs, then the odds were 12 times as likely that they would have attempted suicide than if they hadn't experienced any ACEs. Here's consider self an alcoholic, and we can see again that the likelihood that a person is an self-reported alcoholic increases with the number of ACEs to the point where a person who's experienced a number of ACEs is anywhere from 5 to 7 times as likely to be an alcoholic. Here we see this is the relationship for having used illicit drugs. 11.6% of the sample are reported using illicit drugs. We can see that the odds of a person having used drugs was almost 5 times as great if they'd experienced 4 or more ACEs as compared to a person who hadn't experienced any. Even if a person had experienced only 1 ACE, the odds were almost twice as great. And for 2 ACEs, almost 3 times as great, and so on. If a person reported having injected drugs, it's a small percent of the sample, but we can see that the likelihood increased dramatically as the number of ACEs increased to the point where a person was almost 5 times as likely to have injected drugs. Here's this is a measure. This is an item that looks at promiscuity. And we can see that the likelihood of having had 50 or more intercourse partners is increased to a little over 3 times as great if a person had experienced 3 or 4 or more ACEs compared to people who had experienced no ACEs. This item has to do with ever had a sexually transmitted disease. And we can see that with 3 or 4 or more ACEs, the odds have increased to twice as likely as for a person compared to a person who has had no ACEs. Heart disease, again, the likelihood of heart disease increases with the number of ACEs to the point where individuals with a large number of ACEs, they're twice as likely to have heart disease. And again, we see that the likelihood jumps up to almost twice as great for individuals for the likelihood of having cancer increases to almost twice as great as twice the likelihood if a person has had 4 or more ACEs. Stroke, again, the odds go up for individuals who've had 4 or more ACEs. Chronic bronchitis or emphysema, we see the same pattern where the likelihood of having bronchitis or emphysema increases with the number of ACEs. Diabetes, same, not quite as strong as some of the other relationships, but still a significant relationship. And even having ever had an accident, in this case a skeletal fracture, the odds are greater for individuals with 2, 3, or 4 or more ACEs. And ever had hepatitis or jaundice, again, the odds go up with the number of ACEs. And then on a general health item, you can see that people are over 2 times as likely to rate themselves as having fair or poor general health if they've had more ACEs, experienced more ACEs. And then fear a person being afraid to control, that they will be unable to control their anger, we can see that that fear increases with the number of ACEs, to the point where if a person has had experienced 3 or 4 ACEs, then the odds are 3 times as likely that they feel like they'll be unable to control their anger, and goes to over 4. Like the odds go to over 4 if a person has experienced 5 or more ACEs. So the authors summarize these findings with this diagram, and they say that sort of at the adverse child experiences set in motion a sequence of processes. And so first of all, these ACEs make it more likely that an individual will have social, emotional, or cognitive impairments, which in turn will make it more likely that they'll adopt health risky behaviors, which in turn makes it more likely that they'll experience disease, disability, and social problems, and which in turn will make it more likely they'll experience an early death, which actually, in fact, I didn't show you a graph for that, but the life expectancy for individuals who've had experienced more ACEs also is shorter than for people who haven't experienced more ACEs. So as we look at this, the part of this that might be a little bit of a mystery is why would ACEs be related to health outcomes? And the reason is that the stress response system impacts the immune system. So here's the first phase, or of the stress response system. And we can see that there are excitatory pathways, and these are hormonal pathways, and inhibitory pathways. When the brain is stressed or experiences stress, the hypothalamus releases CRH, and also signals to the pituitary gland to release ACTH, which is adrenal corticotropic hormone, and that stimulates the adrenal gland to release adrenaline or cortisol. And cortisol inhibits the release of CRH, but also impacts the immune system, which I'll show on the next slide. But a really important feature of this is we know that cortisol is neurotoxic, and if it's chronically released, it actually becomes less. It's like your brakes wear out on your car. It becomes less and less effective as a braking system on this stress response system. Here's the sort of rest of the story. We can see that cortisol inhibits the immune cells and inhibits the immune organs, which is one reason why chronic stress leads to various health-related issues. Another more recent research has shown that stress actually degrades the epigenetic, the machinery within the cells, what we call the epigenetic molecular machinery within the cell that is responsible for converting DNA to various structural proteins, including receptor sites on neurons. And as a result, the cells within the body are actually producing degraded versions of the proteins that the body needs to function well. So the impact of stress is there are multiple impacts of stress, and it's extremely harmful. So what the ACEs studies show is that as the number of adverse childhood experiences increases, there's a multitude of downstream effects on a person's ability to control their anger, on their health, on the likelihood they'll commit suicide, the likelihood they'll be depressed, and so on. But what's sort of a hidden part of the story is what we might call what doesn't happen when children are raised in homes where there's multiple adverse experiences. And what doesn't happen is children don't have an opportunity to experience the security that comes through an attachment relationship with a caring adult. And in order to drive this point home, I'm going to share with you another series of studies. These studies were done with rhesus monkeys. They were done back in the 60s and 70s, and are some of the most important studies that have been done regarding the impact of relationships or the lack of relationships on our well-being. This work was done at the Wisconsin Primate Laboratory. This was work done. It was done by the Harlows and then also their student Stephen Suomi. The lab was set up to actually study the neurological mechanisms of learning, but they found that in order to, for a variety of reasons, they wanted to raise their infants, separate the infants from their mothers and raise them, and have the lab technicians raise them. And what they found was that when these little baby monkeys were raised by the experimenters, they became attached to the cloth pads that were used to cover the floors. And if they tried raising the baby infant monkeys without the cloth pads, they actually didn't fare very well. So here's some photographs which show how the infant monkeys, became attached to these cloth pads, which were originally put in the cages for hygiene purposes, and but which the monkeys used as a source of comfort. And this phenomenon is something we're all familiar with from the well-known Charlie Brown comic strip. Which I can refer to here as The Power of the Blanket. So on the basis of these original observations, which were just kind of chance, serendipitous observations, cloth mother surrogates were created, and the researchers realized that there was an opportunity here to test some important hypotheses regarding how we care for our young. And they also created lactating wire mesh monkeys. And so here's two photos which show on the left the wire mother monkeys, and on the right the cloth mother monkeys. The wire monkeys actually had a bottle inserted in them that would, which was where the babies received their nourishment. And in the history of psychology and in general, and in the history of or what we know about parenting and care for the young, more specifically, this was a key this was a key experiment, because both Freudian theory and behaviorist theory predicted that the wire mesh monkey, which mother monkey, would be the one preferred by the baby monkey. Neither theory predicted that the cloth monkey would be preferred, but it was the baby monkeys spent virtually all their time clinging to the cloth monkey and only ventured to the wire monkey when they had to feed. So it was a very strong effect, and the researchers went on to investigate other aspects of this phenomenon. They found that when they refrigerated the cloth mother monkeys, it didn't work. The babies would avoid them, so it was only a warm cloth monkey that was effective. And the researchers went on to conclude that touch was critically important to care of the young. And in one of my favorite articles, Harry Harlow, it's called The Nature of Love. He actually wrote several poems about different animals that care for their young. The one about the elephant reads, "Though mother may be short on arms, her skin is full of warmth and charms, and mother's touch on baby's skin endears the heart that beats within." And then about the rhinoceros, he says, "The rhino's skin is thick and tough, and yet the skin is soft enough that baby rhinos always sense a love enormous and intense." So through a series of studies, in a series of observations, the authors concluded that touching was important in animals, and there's been a variety of authors who've addressed the significance of touch for humans. More recently, Tiffany Field at the University of Miami Medical Center has done some critical work in this area, and among other things shows that the lack of touch in adolescents is related to their levels of aggression. So the previous studies demonstrated that touch plays a crucial role in infant monkeys and other animals, including humans. And what the authors wanted to show in their next set of studies was that the cloth mothers served as a home base for the infants to explore and master the world. So the first thing they did was they developed a fear test. Baby monkeys are terribly afraid of this bear that sort of plays you wind it up and it plays the drum, and it terrifies the baby monkeys. And the monkeys that have a cloth mother to go to the mother and cling as a way to modulate their fear. Likewise, when these baby monkeys are in a strange situation where they have an opportunity to explore, they use their cloth mother surrogate as a home base to explore the world around them. By analogy, this tells us, an important fact about attachment, which is that secure attachments serve as a way to provide human children with a home base to explore the world. And what Harlow's work showed us, that if monkeys lack that home base, their ability to explore was severely limited. And we now know that the same thing is true with human children, that if they lack the secure base that is afforded by a secure relationship with a caring adult, that their ability to master the world both in and out of school is also severely limited. And then the Harlows also showed that if the infant monkeys were separated from their mothers, they would do whatever they could to maintain visual contact. So, which is further evidence of how important these surrogate caregivers were for the baby monkeys. Okay, so to conclude, we can say, fortunately in the real world, real monkey moms combine all these crucial variables, which were separated experimentally in this research program, in a single package. So the real monkey moms are warm, they touch and can be touched, they provide milk, they provide security, and as a bonus, they teach their offspring appropriate behavior. But then there's the question, is mother's love enough? And in order to study this question, the Harlows set up what they call their nuclear family living apparatus, which bears a striking resemblance to the graduate student housing that my family and I lived in when I was in grad school. But anyway, the way this is set up is that it's like a little monkey apartment complex, and there's around in the center there's a free play area, and around that are these compartments where the monkey families lived, and the opening into the center area is small so that only the infants can get into that central area. And so the researchers observed, what did the baby monkeys do, or what did the young monkeys do? And basically what they found was that they went to their own mothers for when they needed comfort, but they went to either into the center area or into other monkey apartments when looking for playmates, and also that the father monkeys were general purpose playmates. A father monkey would play with any young monkey that came into the apartment, but the mother monkeys were very selective and only comforted their own offspring. And through this and other studies, the Harlows concluded that the role of fathers and the role of mothers were different. Both were important. Both set the stage for being able to get along with age mates, and being able to get along with age mates in turn prepared the young for being able to be productive as adults. So that kind of summarizes the role of attachment and parenting. And now what the researchers turned their attention to was, could we induce psychopathology in these baby monkeys? And one of their first finding, or I guess their sort of primary finding in this area, was that abusive mothers were not particularly effective at disturbing development. And they did things like create mother monkeys that had like spikes that came out, every now and then, and although this was distressing to the infants, the infant monkeys developed fairly normally. But in contrast, raising infants in partial isolation, this was very effective at inducing psychopathology. And so when these infants who had been raised alone, or at least primarily alone, were placed in a cage with some of their peer mates, that they would either freeze, or they would run, or they would fight and bite, but they could not get along. When these monkeys that had been raised in isolation grew up and were inseminated, they were not good mothers. They either abused their infants or ignored them, and in some cases even killed them. And here's a disturbing photograph of an infant monkey that had been raised in isolation, self-soothing. So deprivation leads to a strong fight, flight, or freeze response, highly disturbed relationships, and very disturbing behaviors, stereotypic behaviors, and self-stimulatory behaviors. So, of point this out because remember, because we want to remember that what has not happened, all of the care that we normally get from a parent may be as or more important than what has happened. So the ACEs studies show us what the impact of abusive behavior is on adult health and well-being. The Harlow studies show us what the impact of deprivation or neglect is on the development of young monkeys. And in either case, what has or has not happened is all about relationships. In a final set of studies, the Harlows attempted to reverse the psychopathology that they had induced by placing infants in isolation, and they used monkey psychotherapists. Probably should have that in quotes. The patients were 6-month isolates. The therapists were 3-month normals, and they were put together in a quad cage that permitted gradually increasing doses of group play. The key thing here is if the 6-month-old isolates were put in a cage with 6-month-old peers, normally raised peers, the normal peers would reject them and it wouldn't be a healing experience. But if the therapist's monkeys were 3 months, what the typical response of a 3-month-old monkey is to cling. And they're very persistent about this. And when the patient monkeys were placed in the cage with the 3-month-olds, the 3-month-olds would cling and touch and hold. And what this gradually did was begin to undo the effects of deprivation, and pretty soon these monkeys were playing, and you couldn't distinguish the isolates from the monkeys that had been raised with a mother. So you could undo the effects of deprivation, as severe as those effects are, with an appropriate, playful, safe, nurturing intervention. And then one of the things that's striking about this intervention with the peer therapists were that they were playful, persistent, they touched, they were safe, they were accepting, and they were challenged. And this is exactly what we do in TBRI, what we've done in our summer camp, the Hope Connection, what's also done in TheraPlay. So the strikings are, the parallels are striking. So we can conclude that playful, persistent, and challenging interactions can promote healing, but as a bonus, these kinds of interactions also promote the executive functions. What are the executive functions? Executive functions include focused attention, working memory, self-regulation, and then some higher functions including creativity, flexibility, and planning. We know from research with humans that these individuals who are better at the executive functions do better in life, do better in school, do better with peers, and individuals who are poor at the executive functions do poorly in life and poorly in school and have difficulty with their peers, just like the deprived or monkeys in Harlow studies. And what we also know is that certain kinds of experiences promote the executive functions, and these experiences are experiences that are joyful, playful, active, physically active, pervasive in the child's life, relational, and challenging. And what we would like to say is that what, if this is basically a characterization of TBRI. Okay, so what we've shown so far is we've talked about what does happen and what doesn't happen in the case of complex developmental trauma. In the remainder of this, I'd like to say a few things about how it affects the brain, and then a few more things about how we can promote healing. Most of the slides in this next sequence I have adapted from Bruce Perry, who's I think they considered the world's top expert on complex developmental trauma. And one of the things he points out is that for individuals who've experienced trauma, a threat has a double impact. It's a double whammy. First of all, there's the arousal continuum. So this is the fight, fight, or freeze response. And then there's the dissociative continuum. This is the tendency to in a sense, flee in the mind, so to go away. And so a threat has, for individuals who experience trauma, has both effects. Sometimes they're more noticeable. One or the other is more noticeable in our children. So for the child who's explosive, it's the arousal continuum that is most active. For a child who has thinking issues or thought issues, the dissociative continuum is most active. One reason why the impact of threat is so pervasive in its impact on the functioning of the brain and the functioning of and our ability to behave appropriately is that the amygdala, which is the core processor for fear, is connected to virtually all parts of the brain. And so as the amygdala goes, so goes the brain. And we now know this from scanning studies. And it's a central fact of complex developmental trauma. Bruce Perry talks about a continuum of fear, so that when we are afraid or terrified, the brainstem only is active. When we are alarmed, the midbrain may be active. When we are vigilant, and many of our children who've experienced complex developmental trauma are hypervigilant, the limbic system may also be active. But it's only when we're calm that the cortex becomes a major player in our sort of mental orchestra. And as this slide also suggests, this fear continuum has implications for how we sense time. So it's only when we're calm that we can contemplate an extended future and do things like, delay gratification over, many days or weeks, and so on. And unfortunately, many of the kids who have experienced complex developmental trauma, experienced ACEs, are rarely calm. The best they can do is vigilance, and they may spend much of their life in fear or alarm states. Another one of Bruce Perry's insights is that the route of therapy follows the route of development. So we start with the foundation, and so in a sense, we first of all treat the brainstem, and we may do that through music or movement therapy or theraplay. Also, some medications can be helpful. And then we move on to the diencephalon, which is some structures at the top of the brainstem, and so sensory processing activities, touch, music, motor skills are important here. Then we move to the limbic system, which is the motivation system, and we try to give kids experience, with winning or losing, sharing, and so on. And then finally, begin to train the neocortex, which is where which we can do through various games and art activities. Another finding from the research on with children who've experienced complex developmental trauma is that children who are vulnerable, who've experienced trauma, will move into these fear states much more easily than will normal children. And what we also know from the attachment literature is children who have the benefit of a secure attachment are more resilient, and it takes a more serious level of trauma to move them into the fear states. So, the kids who experience trauma, it takes less to trigger an emotional response or a fear response than it does for your normal child or your resilient child. Okay, so now I'd like to switch a little bit into how are we going to work with the kids. One of the things that we know is that there's 3 pillars of trauma-informed care. One is that we have to help create a sense of felt safety in our children. This is primarily done by making an interpersonal connection, and by helping children feel safe, and by connecting with them, we will help them self-regulate, along with various activities such as sensory activities and nurture groups and those kinds of activities. To look at this a little bit more deeply, I want to talk briefly about a paper by Jim Henry, Mark Sloan, and Connie Black Pond, which is in the journal Language, Speech, and Hearing Services in the Schools. And they talk about basically 2 ways to work with kids who've experienced trauma. And each sort of approach is based upon a way of viewing the behavior of these kids. On the one hand, seeing them as willfully disobedient, and the other, seeing their behavior as survival behavior. This is a little hard to read, so I've taken and broken it down into 2 slides. So here's one worldview, if you will, which says that according to this worldview, aggressive children are willfully disobedient. They could behave if they wanted to, and this typically results in power struggles. And power struggles lead to a downward spiral in terms of the relationship between the adult and the child's behavior. The adult experiences increased frustration. They enforce more rules. They enforce the rules more strictly. And meanwhile, the child is increasing their resistance, increasing their opposition, and at the same time becoming increasingly isolated from their peer group. And this is a downward spiral. This can only lead to, kids, being, placed in special placements where the downward spiral is likely to happen all over again. On the other hand, we can recognize that aggressive behavior is survival behavior. It's part of the fight, flight, or freeze response. We can focus on the felt safety of the child. If we can help a child feel safe, we can reduce our frustration through compassion and understanding. We can try to give a child a voice. Help. One of the strategies we use in TBRI is to ask children what they need, which is giving them a voice. We can affirm a child's feelings of fear and anger. We can recognize those fears, the sources of those fears, and we can help children learn to use their words. We know this approach works from a variety of sources of evidence, but I'm just going to share one with you here. And this is from one of our summer camps where we measured salivary cortisol prior to camp and during the first week of camp, and then during the second, third, and fourth week. And what we found was that when kids began to feel safe during the second week, their cortisol dropped to normal levels. The green line represents normal levels. The red line represents a level that has been found in children who have experienced complex developmental trauma. So by helping children feel safe, we begin to see behavioral change. We also see an explosion of competence, or what appears to be an explosion of competence, because as children begin to feel safe and feel secure, they literally gain access to more of their brain, or more of for example, we have seen explosions in language with kids at our camp. 2-year gains in one summer. We've seen kids, their cognitive competence increase dramatically, and so on. So that's complex developmental trauma. What we've talked about is we've talked about the impact of adverse childhood experiences. We've talked about the impact of deprivation. We've talked about the importance of touch and security and nurturing. We've also talked about the impact of trauma on the brain, and we've talked about a few avenues for helping these children who definitely can be helped. And we thank you.